Hey everybody, I don't have a ton of blood and guts to show you this time around. Got a little bit more chill stuff, but we're going to talk about evidence-based medicine, how that impacts EMS, pre-hospital care, and our protocols. And whenever I say evidence-based, it can get complicated, but we're trying to work through just cold hard data that can be implemented into the protocols to save lives. Imagine trying to treat patients today using protocols from the 70s. The beauty of evidence-based medicine is that it is constantly evolving, and that's keeping us at the most responsible approach towards our patient care. So what exactly do we mean by evidence-based medicine? Essentially, it's about integrating the best available research, clinical expertise, and patient preferences to guide our decision-making on scene. It's really how we decide which interventions to prioritize, what drugs we're going to administer, and when we're going to implement new treatments. Let's take a step back into history. Talk about some tools that might make you cringe a little bit today. Just take the oral screw, for example. A legitimate tool, and that's what it's called, an oral screw. This was a device that was used to keep the airway open, or actually open it, when someone was having a seizure. Spoiler alert, it didn't work good. There's also the mast pants, inflatable trousers that were used to treat shock by the thought of squeezing blood from the legs up into the core. I mean, it sounds legit, but it turns out studies showed us that using these mast pants didn't improve survival, and in fact, it made things worse by increasing pressure and caused more complications. This is a great example of how evidence-based medicine stepped in and said, hey, look, this isn't working. We need to try something else. The power of research retired those tools for good, at least in pre-hospital care. So let's really jump into this system for understanding these recommendations, specifically how the class of recommendation, or COR, and the level of evidence, or LOE, work together. All right, so first up, we've got the class of recommendation. This tells us how strong the recommendation is based on the evidence. Class 1 is strong. This is where the benefits far outweigh the risk. For example, CPR, simply that, CPR during cardiac arrest is a class 1 recommendation. You'll often hear terms like is recommended, should be performed, or indicated for these types of interventions because research consistently shows these actions are beneficial and necessary. Now there's a class 2A, this is more moderate. Here, the benefits are still going to outweigh the risk, but with slightly less certainty than that of class 1. You might hear phrases like is reasonable or can be useful, meaning that this intervention is probably beneficial, but not as definitively supported by data that we would find in class 1. Now there's class 2B, which is weak. Now this is where things start to get uncertain. The benefits might be equal to or just slightly better than the risk, and the phrases you'll see in this wording is a lot of things like may be considered or might be reasonable. At this point, the evidence isn't strong, and the intervention may only be helpful in certain scenarios. Now there's class 3. We've got two categories of class 3. First is simply no benefit. This is where the risk and benefits are either equal or there's simply no benefit at all. Here, you'll find phrases like should not be performed or is not recommended. There's also class 3 harm. When you see a class 3 harm recommendation, it's because research has shown that the intervention is outright dangerous. Like it could cause serious harm or even death. Here you're going to hear terms like is potentially harmful or should not be performed. Basically, we're steering clear of any of these interventions. Now there's another side of this research evaluation, and that's going to be the level of evidence. This adds a second dimension, really, by telling us about the quality of the evidence that's backing these recommendations. First, we've got level A, gold standard. The evidence comes from multiple randomized controlled trials, robust meta-analyses. You can trust these recommendations because they're based on the highest quality studies. Next up, we got level B. Two categories for this. There's level BR, meaning randomized. Here you still have solid randomized trials, but a little bit less consistent results than we would find in level A. Now there's level BNR, which you can guess, non-randomized. This evidence is based on well-executed, non-randomized, observational or registry type of studies. Next up, we got level C, LD, meaning limited data. Here you're dealing with the studies that might have design limitations, or maybe there's just not enough data. These recommendations are based on less reliable research. Another level C, that's level CEO, or expert opinion. When there's no substantial data available, recommendations are based on expert consensus. While this is still useful, it lacks the rigorous research backing of the quantitative evidence that we would get in higher levels. So, in short, COR tells us how much we can trust an intervention, and the LOE tells us how solid the evidence is behind it. And I get asked all the time during our in-person con eds whenever we're talking about protocols. Why did Narcan get taken out and then put back into the cardiac arrest protocol? So many questions about it. All right, so let's really use this evidence-based class to dig into that and see how these decisions were made. So we're gonna have to go back to 2010 to start understanding this. In 2010, the AHA released guidelines that advised caution when using naloxone during cardiac arrest. At that time, the focus was and still is on ensuring high quality CPR as the priority for managing opioid-induced cardiac arrest. Now, this approach was based on the understanding that once a patient has fully entered into cardiac arrest, restoring oxygenation through CPR was seen as the primary intervention. They weren't really sure about the reversing effect of the naloxone. So in these 2010 guidelines, it was particularly noted that the majority of opioid-associated cardiac arrest present with non-shockable rhythms like PEA or asystole. They used data from multiple studies that showed fewer than 10% of these opioid-related cardiac arrests occurred with shockable rhythms like VFib, VTAC. Grim prognosis for non-shockable rhythms made it even more crucial to focus on the immediate CPR and ventilation. Naloxone simply wasn't seen as a priority. But whenever fentanyl showed up, by 2019, the nature of the overdoses had shifted dramatically, as most all of us saw. Fentanyl was far more potent than their typical heroin or other prescription opioids, and this made us change everything. The fentanyl was causing faster respiratory depression and then moving into respiratory failure. One thing this problem provided, though, was a lot more data to learn from. So in 2019, a systematic review led by the Agency for Healthcare Research and Quality provided a foundation for new evidence-based guidelines regarding the EMS administration of naloxone in opioid overdoses, and this also include out-of-hospital cardiac arrest with opioids. The review brought attention to the evolving nature of this crisis. In fact, in 2017, fentanyl accounted for nearly 30,000 of the 70,000 drug overdose deaths in the United States. This 2019 study also highlighted that EMS calls involving the administration of Narcan increased dramatically by 75.1% during the times between 2012 and 2016. So this 2019 guidelines pointed out a lot. Early naloxone use before or even at respiratory arrest can prevent progression to full cardiac arrest. Basic life support providers administering naloxone were found to be just as effective as our advanced life support partners. Research showed that they felt naloxone was basically neutral in cardiac arrest. Because of this, they have placed the emphasis of high-quality CPR, especially on the BLS provider, as the primary treatment. That's why we at the EMT level were specifically impacted, because high quality CPR, already known to be a requirement for eventual ROSC, along with the ALS interventions, was placed at the priority. Now, there was even some other research that showed that too much faith was being put into Narcan during cardiac arrest, and that caused some responders to withhold CPR or at least delay it. So now let's look at 2024, specifically August 20th. New study from California, 8,000 out-of-hospital cardiac arrests between 2015 and 2023 were analyzed. The study found that 14.2% of these patients had naloxone administered during resuscitation. But here's the kicker. Naloxone use was associated with a 15.2% increase in return of spontaneous circulation. Additionally, there was a 6.2% increase in survival all the way to hospital discharge. These numbers are significant, especially considering the historically low survival rates for non-shockable rhythms. What's groundbreaking about this study is that it challenges the earlier hesitations from 2010 and 2019. Not only did Narcan help with ROSC, but it improved long-term survival. So these findings echo what we saw in another 2024 Portland study, where naloxone was directly associated with higher odds of ROSC, survival to admission, and even discharge. It even pointed towards better neurological outcomes in those patients who had those non-shockable rhythms. In this Portland study, patients receiving naloxone had a 4.6 times higher chance of surviving. That's a game changer and explains why the protocols were adjusted back to integrate Narcan more aggressively in opioid-related arrest. Talking about evidence-based research, let's use this Narcan example to hone in on what the quality of the research was during these different years. So the 2010 evidence for naloxone in cardiac arrest was weak. The decisions were driven more by expert opinion and clinical experience than large-scale data. The research used limited data sets, focusing mainly on post-event data analysis and general psychological trends in opioid overdoses, so it was largely observational in nature. Retrospective reviews and observational reports offering that Class 2B a weak recommendation. Let's take a look at the 2019 review and how that started shifting focus around. Instead of observational studies, we jumped into random trials, large-scale population data. This increased the reliability of the evidence. However, it also exposed some gaps in the data, especially concerning naloxone's role during full cardiac arrest, making it a secondary consideration after CPR. Still like it is now, but it was less clear. We know that the calls involving Narcan administration surged 75% during that jump from 2010 to 2019, but this review now had 700 studies with a particular focus on overdoses in the pre-hospital environment. It was considering BLS and ALS interventions, and it examined patient outcomes with and without early Narcan use. This research's design was more systematic literature review of these random controlled trials, retrospective studies, and case study series. It was certainly better evidence, like moderate, but definitely not definitive. So as we know, we got Narcan back in our protocols a while ago. I wanted to pull the most recent research I could to show the evolution. Now, looking at the specifics of the August 2024 study that came out of California, sample size 8,195 patients were included. Let's talk a little bit about statistics. The study used nearest neighbor propensity matching along with a inverse probability weight regression adjustment to control for demographics like age, initial rhythm, and comorbidities. I know I just used a lot of words, so let's look at how these statistics were actually worked out. The nearest neighbor method, it pairs two patients from two separate groups, so those who got Narcan and those who didn't during cardiac arrest. Right, so they've got also similar characteristics like age, health backgrounds. It's like finding a twin in an opposite group to compare, and so that's going to ensure that the outcome difference is due to treatment, not other factors. So one way you can look at this type of research is when you go to the beach. It's safe to say that when ice cream sales increase, so do shark bites. With this, it's pretty simple to see that they're not directly related. Both of them are going to increase whenever the population increases. So nearest neighbor propensity ensures that there is actually causation between the two variables. The study's large sample size and careful statistical design really provided that strong support needed for the inclusion of Narcan in opioid-related cardiac arrest protocols, even for patients presenting with non-shockable rhythms. So just to summarize our Narcan example, in 2010, decisions were based on expert opinion and small observational studies. 2019, we have more data. Systematic reviews of literature provided more context and clarity towards Narcan's pre-hospital role. Finally, here in 2024, using advanced statistical methods, a huge sample size, we're able to demonstrate concrete benefits leading directly to ROSC and hospital discharge, which makes Narcan a key tool in managing opioid-associated cardiac arrest, specifically in non-shockable rhythms. How does all this research-based stuff impact North Carolina EMS protocols? Our state is constantly revising its approach based on the latest evidence. It's no secret, protocol changes will be coming in early 2025. Will they affect us as EMTs here in Guilford County? I'm not sure. But when changes do come, let's make sure we're squared away on actually reading them. It's not as complicated as it looks. Each protocol starts with the most critical interventions at the top, works its way down to secondary considerations. Well, let's really look into what these protocols actually are. Here we have a blank protocol. You can see that this is going to look very similar. It is just defining what all of these boxes are. Starts at the top, history, with different important items, things you're going to see in sample, how long to expect things to last. Signs and symptoms, pretty self-explanatory. What are you expecting to see with these patients? From there is a differential. Now, these are a list of other diseases or injuries that you should be considering might be a cause of something during your assessments. So from there, in the middle, we're going to talk about the Universal Patient Care Protocol. This is where they're listing out the basic foundation part of your patient assessment. Then over on the right, you've got the red box. This is the most critical information, and it might even direct you to another protocol. We've got other areas that are going to get more specific, where we talk about contacting medical control for certain medications. And then information boxes are going to have this purple shading. This might be agency-specific information. The local medical director, it's really their spot to put notes where they want them. The legend for the overall algorithm. So if it is a blank box, then that is an emergency medical responder level skill. If it has a B there, then that's for us, EMTs. So we can do the blank box and the box with the B. But where we have to stop is the yellow A. So that is for the advanced EMTs. And of course, you've got the blue P for the paramedics as well. So those two boxes out of our scope. If you see the last box, that means that you're being triggered to notify and contact medical control. Don't overlook the second or sometimes even third pages of some protocols though. This one is for cardiac arrest in adults, but it has notes directly from the medical director in that purple background box. And then we've got the pearls section. This is going to give you all those bullet points, and it might even trigger you to go and start researching something yourself, as they don't provide a ton of explanation, but they're very direct, blunt, to the point instructions or differentials for some things that might be going on. Keeping with our overdose and Narcan administration example that we used earlier, here's the overdose protocol, the first page of it. And right up top, you can see where we have the history section, signs and symptoms, and then the different differentials. But right out from the gate, it starts with inadequate respirations, oxygenation, or ventilation. If it's yes, at this point, it's saying go straight to naloxone, right? We talked about our dosages in our last in-person EMT. So you would give that as indicated and then move on. We have our green box here, which is saying that we're going to exit out to our appropriate protocol, which would be airway. So now we're here at the airway protocol. We're again assessing respiration rate, effort, oxygenation, and if anything's wrong with that, then we have our blank box here, meaning this is going to be for all levels. Basic maneuvers first. Opening the airways, nasal or oral airway, bag valve mask with our PEEP devices. From there, we've got several other protocols that we should consider. Do we need spinal immobilization? Is there an altered mental status that we need to be addressing? This is going to take us all the way through obstructed airways, down to additional breathing and oxygenation support. If that patient codes, we are going over to our cardiac arrest protocols. Here's the one for the adult. You can see the red box. Remember that that was for really important information that needs to be highlighted. And then it goes through our usual plans. What's relevant here is that after we've done a ton of stuff, now we're asking ourselves, is the arrest secondary to an opioid overdose? If we think it's yes, then we give Narcan. The main thing is that this protocol is dictating that everything up here is taken care of. So as you can see, evidence-based medicine, it's really forms the foundation, especially of our modern day EMS systems. It's going to ensure that we're using the latest possible data to save lives. Whether it's removing ineffective treatments like those masked pants or integrating life-saving medications like Narcan appropriately into our skills. It's going to impact everything that we do for the rest of our careers when it comes to EMS response. That's all I got for you. Thank you for taking the time to check this out today. Stay safe. Have a good one. We'll see you out there.